minimize that, man, and it'll still record.
Okay. All right. Okay. So what is histology? It's the microscopic study of tissues. So when we talk about it in the pathology laboratory, we generally talk about histology is what we look at that's a paraffin-embedded tissue under the microscope. It's more of a chunk of tissue, whereas cytopathology usually deals with the cells in a fluid suspension of some kind. So we don't have that microscopic anatomy generally in cytology, but in histology we do, and that's what this lecture is going to focus on, is really the microscopic architecture of different cells and organs. So a tissue is a conglomerate of cells working together to achieve some function, and a bunch of tissues together aimed at one goal is referred to as an organ. So the major types of tissue, epithelial tissue, connective, muscle, and nervous. And this is helpful as a cytologist because we're generally trying to put things into a general category as a cytologist. So am I dealing with an epithelial process? Am I dealing with a connective tissue process, muscle, nervous system, etc.? So these are the general categories that when we look at an FNA or fine needle aspiration, we are trying to put them in the most broad sense into what am I dealing with first? Is it epithelial? Is it connective? And so on. So this is really the foundation of our cytologic approach. When we look at tissues generally in the pathology laboratory, we're talking about an H&E or a hematoxylin or eosin stained slide that's been paraffin embedded and fixed and put on a slide. There's also immunohistochemistry, which is becoming increasingly important. And this immunohistochemistry is a way to interrogate cells in terms of what kind of sugars or proteins they express. And this comes in handy with different types of tumors because different types of tumors express different kinds of proteins, different kinds of sugars. And so that we can exploit that. So if we're trying to figure out, is this tumor from the pancreas or is it from the colon? Then those two tumors are going to have different types of immunohistochemical profiles that we will exploit later. And this will, and then you'll talk about this much more later in the semester, but I just want to introduce the concept now. There's also electron microscopy, which is generally only used nowadays in terms of renal biopsies, looking for different types of kidney diseases. It does not really have a place in the everyday pathology laboratory. We don't even have one at SAMC, which is the largest hospital in the DoD. We don't even have an electron microscope or a pathologist who's trained to use it. And so when we have those kidney biopsies, they go downtown to UTSA to be looked at. They go to a specialist. So EM used to be very, very important, but now it's less so, except in terms of renal pathology. All right, so basic cell characteristics, and this is what we're going to be very concerned with as cytologists, is the nucleus and the cytoplasm and their relationship. What do they look like, and how big are they in terms of relationship to one another? So cytoplasmic characteristics that we're going to be interested in are the size, the shape, and the staining properties of the cell. Does it take up stain really well? Does it not stain very well? Does it look granular? Does it look empty? Does it have a big vacuole? These are things that we're going to be looking at as cytologists. But it's going to reflect what that cell is actually doing. Does it have, does it secrete? Does it store? Is it like a fat cell? Does it store fat, or does it make granules to be secreted? We'll talk more about that later. And this is very important in terms of classifying where that kind of cell is coming from. Nuclear morphology is important, really not so important in determining what that cell does, but whether it's benign or malignant. And that's it's difficult to appreciate. I'll show you some pictures later on. Again, here are these broad tissue categories. Epithelia or epithelium is singular. It's the lining membranes. And when I was in college and I took a histology course, when I was 20 years old or something, the professor said, if you want to figure out if something is epithelium, imagine yourself really, really small. And if you entered someone's body and you were really tiny and you could walk there, that's epithelium. So just imagine that you are really small and you pop in someone's mouth, and so all their mouth is lined by epithelium. You crawl down their esophagus. That's all epithelium too. The lining of their stomach, the lining of the intestines, all of that is epithelium. And if you couldn't walk there, being a tiny person, again, it's like a leap of the imagination, it's not epithelium. So just think of it that way. If you're wondering if this is epithelium or not. That doesn't always hold true, but as a general rule, kind of like the lining of the bladder, the urethra, the lining of the vagina, all those things are epithelial. Connective tissue refers to the supporting tissue that lies under the epithelium. And then we're going to talk a little bit about the mobile cells, so the cells of the bone marrow and the peripheral blood. You guys already had an embryology lecture, so I'm not going to belabor this because it's pretty painful and complicated. But in general, the endoderm refers to the gut, the respiratory lining, the viscera, the endocrine, so things that are very much on the inside, whereas the ectoderm is the outside. If you remember from that embryology lecture how we develop as embryos, it does make sense, although it's complicated. So the central nervous system and the peripheral nervous system are ectodermal, as are the epidermis and the adnexal glands. The breast and dental enamel are also ectodermal. In practice, I know you have to learn this for tests, you do, but in real life, don't worry, this is not going to be as important as it seems, which should be some solace. So, mesoderm refers to connective tissue. So meso means middle, so you would think of things that are in the middle, like connective tissue, striatum, smooth muscle, the heart, blood, lymphatics, etc. Okay, so again, talking about the epithelium. So what is it? It's what covers the free surfaces of the body and composes the functional units of glands. It's derived from all three germ layers. It depends on where it is. No blood vessels are present in epithelium. So the epithelium has to be nourished by vascular flow from below, from that connective tissue. We'll talk about that a little bit later. But there should be no blood vessels present in the epithelium itself. Epithelial cells reproduce themselves through mitosis. And we're going to talk a lot about this classification because this is important, whether it is simple versus stratified, and whether it's squamous versus cuboidal versus columnar. And we have a bunch of pictures to go through these. All right. Any questions so far? Okay. All right, so simple epithelium just means it's one layer. There's squamous, cuboidal, columnar, and pseudostratified columnar, even though it's still simple. Let me catch up with my notes here for a second. All right. And stratified can be the same. It just depends on whether it's one layer or multi-layer. That's the difference between simple and stratified. So simple squamous epithelium examples. The lining of the pleura, which is the lining of the lung cavity, both against the lung and on the chest wall cavity has a pleural lining, which is called mesothelium. The pericardial sac and the peritoneal body, or the mesothelium, is a simple squamous epithelium, as is the lining of the lung, the capillary endothelium, and the lining of the kidney, which, again, as cytologist is not so important. But mesothelium, as a cytologist, is very important. It's very important to recognize what mesothelium can look like because we encounter it all the time. In fact, I often think that mesothelial cells are the reason why there is a fellowship in cytopathology, because they are very difficult to recognize and they can be very problematic and can mimic cancer. And so I think that that's actually why the fellowship exists, because of the mesothelial cell and because it's such a nuisance. So we'll talk about it a little bit later. So this is the lining of the peritoneal cavity. And if you look down on it, it's made of these plates of flat squamous cells. Here, they're very polygonal. They have a lot of cytoplasm and a very small round nucleus, which can be in the middle or it can be rather eccentric. But the point is they have abundant cytoplasm. And this NC ratio, you're going to hear the words NC ratio probably about 800,000 times by the time you finish this program. It's very important in cytology. But these have a very low NC ratio. They have a very small nucleus and a very big, voluminous cytoplasmic volume. And this is a simple squamous lining. And this can become important because this lines the peritoneum and it lines the pleura. So, to bring it back to cytology, if a radiologist is doing a final aspiration through the chest wall, he can catch some of these mesothelial cells on the way. And then you can wonder, are these coming from the lung? Were they just an innocent bystander on the way to get that biopsy? So it's always something to be very, very important to be not cognizant of is what is that needle passing through on the way to get that tissue? Because they're not always going to give you diagnostic tissue. You'll find out right away. They often don't. But they will give you things that they captured along the way, like a sheet of mesothelial cells. And you have to figure out, are these mesothelial cells, or is this a squamous cell carcinoma or something? And also, let's just talk about terminology quickly. So you'll hear the word squamoid often. So squamoid does not mean that it's squamous, for sure. Squamoid means that it's squamous-like. Squamous-like is the same as squamoid. And so when we refer to something as being squamoid, it means this. So picture this in your head. So it has a big kind of voluminous polygonal cytoplasm and a small little nucleus. When someone describes something, a lesion or a tumor or a normal tissue as squamoid, it means this. This is the look that they're referring to. They're trying to conjure this in your mind's eye by using the term squamoid. Okay? Now, when you look at that same sheet, so this was looking down on it. But when you look at it the other way, you tip it on its side, it looks like this. This skinny little line of cells here. So this is looking at it from the other way. So you have to kind of tilt it in your mind. Everybody's, all right, you're with me? Okay, I'm not a good spatial thinker, so I have to, think about it a lot. But so this is what they look like from the other way. Another example is the lining of the lung. This is normal lung. This is the alveolar sac, and it's lined by this simple squamous epithelium, flattened. All right, the lining of this is Bowman's capsule. So this is the glomerulus, this tangle of capillaries sitting in this cavity. That's the glomerulus. So this is the functional unit of the kidney. This is where blood is filtered. And then this is Bowman's space, this empty space, and Bowman's capsule is here. And you can almost see these attenuated. So attenuated means thinned out and skinny. That's a word we use a lot, attenuated. This attenuated epithelium lining Bowman's space, and that's Bowman's capsule, and that's an example of a simple squamous epithelium. There aren't too many examples of simple squamous epithelium, so. All right, simple cuboidal epithelium. So cuboidal, just what's a cube? It's a little box, right? It's a little box, so we'd expect it to be little boxes, and that's exactly what it is. And so some examples are collecting ducts of the kidney, the thyroid gland, which as cytologists we become very, very familiar with because thyroid FNA is one of our major specimens. In the embryo, you see this often. You're not going to encounter, it'd be very unusual to encounter embryonic elements. As a cytologist, it's generally more the purview of surgical pathologists, but it's good to be aware of it. And the choroid plexus surrounding the brain. We'll see some examples. All right, so this is the renal tubule here. These little tubules, and you can see these cells are just little boxes. This is a simple cuboidal epithelium here. Another example is in the thyroid. And the follicular cells, when they are normal, are just square little boxes. These are follicular cells, and this dense pink stuff is colloid here. Simple columnar epithelium. So columnar, what do you think they're going to look like? Columns, rectangles, right? They're going to be tall, skinny rectangles, exactly. So we're going to see this often in the intestine, the gallbladder, stomach, a bunch of places actually. And it looks like this. So this is the small intestine. These are villi. So villi refers to finger-like projections. Looks like this. Increases the surface area for absorption. So in people that have, for instance, like diarrheal episodes due to celiac screw or gluten-free diet, etc. So when someone has that disease, they don't look like their intestines don't look like this anymore. It looks like this. So they've lost all that surface area. So they can't absorb all the nutrients. So they have a chronic watery diarrhea because they've lost that absorptive power. So that's the morphologic correlate for that disease. But I think we'll have a better picture. You can kind of appreciate how these are just tall, skinny rectangles, one after the other, of this epithelial lining here. This is a better picture of the gallbladder. Again, tall, skinny rectangles, one just like the other, with a basally oriented nucleus. In the endometrium, depending on the cycle, the epithelium will be tall and skinny. It changes throughout the cycle, but in the proliferative phase, it's a tall, skinny rectangle or simple columnar epithelium. All right, so pseudostratified columnar is not as common, but you see it in the large ducts of the respiratory tract fairly frequently because FNA of the lung and lung masses is very, very common. So this is something that as cytologists we will encounter. So you see it in the trachea and the large bronchi, you see it in the vas deferens, epididymis, and the male urethra, and really just large ducts of any kind. And so it's pseudostratified because what does pseudo mean? Right, not or false. And so it appears to be stratified, but it's not. And so what that means is that it looks like there's a jumble of cells here, and they're two layers, but in fact there's only one layer because each cell is kind of extending like one little process down to the basement membrane. So although it appears to be several layers, it's actually just these cells are all touching the basement membrane, so it's actually pseudostratified columnar. So this is what the male urethra looks like. Again, these tall, skinny cells that appear to be in two different layers, but they are in fact just one layer because they're all touching the basement membrane. You're going to see a lot of these as cytologists. This is the trachea. You can see here the ciliated border, the brush border here. And then here the bronchoepithelial cells with basally oriented nuclei. And these little dark guys at the bottom, these are reserve cells here. So all of it, even though the nuclei are at different levels, again, this is pseudostratified because each of these cells is touching the basement membrane. Stratified squamous epithelium is the most abundant because it covers our entire skin surface. So you see it on the outer skin, in the mouth, in the pharynx, in the esophagus, anal canal, etc. And it looks like this. So the oral mucosa, it's non-keratinized, which means that you have no keratin layer. And we'll show an example of that in just a second. So there are nuclei going all the way to the top. Here they mature. This could also be the vagina. It looks the same. So it has no keratin layer. So this is what oral mucosa looks like. The vagina looks identical. You would not be able to tell the difference. However, this could be the hand or anywhere else that has a keratin layer. So any place that gets more abrasion or rubbing is going to have more keratin. So, for example, in us, let's see if I have an example. The esophagus is non-keratinized. But in cats, because they're like swallowing hairballs all the time, they actually have a keratinized esophagus. So it just reflects the function. All right, here's another picture of stratified squamous. You have cells at all different layers. And then they lose their nuclei at the top, and you just get keratin here. This isn't one that, oops. All right, stratified cuboidal epithelium, there aren't very many examples of it compared to the other kinds of epithelium. The ducts of sweat glands are stratified cuboidal. The female urethra, again, as cytologists, that's not going to be something that we sample generally. Portions of the anal canal and the conjunctiva, again, these are not areas that are typically sampled by cytology, but it's important to know about them. This is an example of stratified cuboidal sweat duct. So you have these two layers of tall, rectangular, skinny cells. You can see it's kind of bilayered here. And this is truly stratified because that top layer is not touching the basement membrane. We just spoke about that. It's pretty much the same thing. Stratified columnar is pretty unusual, and you see it in large ducts of glands. So this is the cystic duct of the gallbladder. So you have stratified columnar, long, skinny cells in basically a bilayer. Transitional epithelium is sort of a misnomer that we are getting away from because it kind of makes it sound like it's on its way to being something else, but it's definitely its own type of epithelium, and this is just a historical term that has been hard to shake. So much so that urothelial carcinomas for years and years and years have been called transitional cell carcinoma, or TCC. You'll see this when you are a cytotechnologist and you're looking at urines. It's going to say rule out TCC, and TCC stands for transitional cell carcinoma. But that's not a term that we use pathologically anymore. But it's just embedded in the medical nomenclature. So It would probably take a long time to get rid of it. But what it refers to is urothelium. So the epithelium that lines the urinary bladder, the ureter, and the upper urethra. And the transitional name sort of refers to the fact that it's kind of squamous and it's kind of cuboidal, depending on when you look at it. And if the bladder is very distended and you take a biopsy, it's going to look very stretched out. And if you take a biopsy when the bladder is kind of squunched down and empty, that epithelium is going to look a little bit different, and it just has to do with the distensibility of the bladder. But this is what the bladder looks like here. Has loose lamina propria, and then cells that are somewhat squamous, but not exactly, because they don't have very voluminous cytoplasm. Again, this is referring to its name as transitional. It's kind of in between. It looks kind of cuboidal, but it's kind of squamous at the same time. And that's why that name transitional came into being. Now, what does epithelium do? It generally provides mechanical protection from the outside world. Also, it fosters exchange with the outside world. Fostering production, reproduction takes place across epithelial structures. Nutrition and support, and it synthesizes and releases products. So in terms of the skin, it offers mechanical protection. So the skin of the palms of your hands and the soles of your feet are going to have very, very thick keratin to protect those surfaces, because you're interacting with everything all the time and stomping on the ground. And so in order to provide a barrier, it's heavily keratinized, whereas the skin on your eyelids has hardly any keratin, because nothing ever happens to your eyelids, hopefully. Bronchial lining provides exchange. This is a typo with the outside world. So here's this bronchial epithelial lining here with its cilia, and the gas exchange takes place in the alveolar sac further down the lung. The GI tract absorbs food. So I was referring to the example of celiac sprue. You have to have lots of villus surface area to appropriately absorb nutrients and water. So endocrine glands secrete their products directly into, we're going to turn to glands now, sorry. Endocrine glands secrete their products directly into the bloodstream. So they're not going to have, it's not going to be a gland with a little duct that then dumps out into something else. That's an exocrine gland. We'll talk about that in a second. But an endocrine gland releases its product directly into the bloodstream. And you'll see pancreas listed both under endocrine and exocrine, because there is both endocrine and exocrine function of the pancreas. So the endocrine pancreas is best known for releasing insulin into the bloodstream from the islets of Langerhans. Okay. The adrenal gland, which is its name comes from the fact where it sits. So it's right by the kidney or renal. So it's adrenal. It's a little kind of bean-shaped organ sitting right above the kidney. The thyroid, which we've seen pictures of, right here, it's a butterfly-shaped gland in the neck, and it releases its stored hormones directly into the bloodstream. And the pituitary gland, which is sitting at the base of the brain, also releases hormones directly into the bloodstream. This is another picture of the thyroid. So this is colloid. This is where thyroid hormone, once it's synthesized, is stored in these big pink lakes called colloid. And you'll see this all the time on FNAs of the thyroid. This is what normal thyroid is supposed to look like. And again, here's this simple cuboidal epithelium. And when these cells secrete this stored material, it goes directly into the capillaries. As you can see, it's very richly vascular. It has many, many, many capillaries that surround it. So this is as opposed to exocrine glands, which secrete their product into a duct, and then that duct, kind of as like a little plumbing system, takes it someplace else. So this would be the exocrine pancreas, and digestive enzymes that are released into the gut from the exocrine portion of the pancreas, as opposed to the endocrine portion of the pancreas. Sebaceous glands are the same way. Sweat glands are the same way. Sweat glands are probably the easiest to understand. Because sweat glands are in your skin. You sweat and it dumps out on your skin. That's kind of, if you think about that, then you understand an exocrine gland. The breast is basically a modified sweat gland with breast milk. It's the same thing, synthesized like deep in the breast and then secreted, through the nipple. That is, if you think about that, that's an exocrine gland classically. And it doesn't matter whether it happens on a level that you can see or whether it happens on a microscopic level, that's an exocrine gland. Salivary glands are the same way. Exocrine glands have some classification, which is important just to know. It's probably not terribly important as in everyday practice. But a holocrine secretion refers to a whole cell that's secreted. So a sebaceous gland secretes its entire cytoplasmic contents into the duct. Apocrine gland is the protrusions of the apical cytoplasm, so it kind of like pinches off little bits of its cytoplasm. So breast milk is just kind of like the cell manufactures what will become breast milk and then packages it in little sacks basically and sends those down the duct but the cell itself stays intact. Whereas in merocrine secretion, no cytoplasm is lost at all. And so this is in salivary glands and goblet cells when the cell manufactures little secretory granules, and just that little granule is secreted, not any of the cytoplasm, and definitely not the whole cell itself, as in holocrine secretion. All right, this is kind of upside down, but these big empty cells are sebaceous glands here, and this is again the example of holocrine secretion. The entire cell is secreted into the hair follicle. And this is why your hair and your face get oily, because they have a lot of these sebaceous glands on them. But the palms of your palms never get oily because they don't have any of these. And these are little sweat glands here. Serous salivary glands look like this. So this is all that empty area is fat. This is a duct here of the gland. So these serous, they're called acini, or little grape-like structures. You can appreciate how granular they are. So those granules are going to be secreted. They're going to travel down these little tiny ducts into this large duct and be secreted into the mouth to help digest food. This is a mucous salivary gland. So instead of these dense secretory granules, they are filled with mucin. So this is a mucous salivary gland and a duct here for the simple cuboidal epithelium. And salivary gland frenulal aspiration is fairly commonly performed, so it's important to know what's normal in the salivary gland. So if you stick a needle into the salivary gland, and it's normal, you're going to see little fragments that look like this, like little grape-like structures with some admixed fat and maybe some duct. You might also see some mucous salivary gland. So it's just the most important thing is to know what's normal. In the site that I'm looking at, what's normal. All right, so the nourishment and support of reproductive cells is generally epithelial in nature. In the male, we have the epithelium of the testicular tubules that produces spermatozoa or sperm or spermatids, same thing. The prostate and seminal vesicles produce fluid or the semen that's important for sperm survival. Sperm can't really survive on their own. They need the nourishment of seminal fluid in which to live. In the female, the ova or oocytes, or the egg, is produced by the ovarian epithelium. The fallopian tube, which is ciliated, propels the egg. So you guys just had that lecture today. So you know that the egg is released, but the egg is released actually like in the peritoneal cavity. It's quite remarkable. And then it gets into the fallopian tube, and the fallopian tube goes like this, like beats, right? It beats, and it pushes the egg down into the uterus. And actually, people that have genetic diseases that kind of paralyze their cilia, they have trouble getting pregnant because they've lost that motility. So the egg just kind of sits there and it doesn't get pushed downstream. Similarly, in men, they don't have the cilia needed in the vas deferens. So the endometrium supports the implantation of the fertilized ovum, and then in terms of just intercourse, the vagina provides some mechanical protection. So this is a testicular tubule. This is not something that you're going to see as cytologists very often, because in general, FNA, or again, frenulal aspiration of the testis, is contraindicated, because it's thought that if you stick a needle into a tumor of the of the testis that then, and there's tumor there, and as you pull out the needle, you can spread tumor along the needle tract, which is called seeding. And that's why you almost never see FNA of the testis, because of this. You don't want to, they don't want to contaminate with potential tumor. So, but it's important to know in case you ever see it. So this is testicular tubule here. These are spermatogonia, or primitive germ cells, and they undergo meiotic divisions to become mature spermatids, which are these like small angulated dark cells here. This is mature sperm. It gets down to just, it's like a little like DNA warhead, just like waiting to go. But it starts out as a much larger cell. Yeah. It gets down to like almost nothing. It's just DNA, hardly anything. And the prostate gland, again, prostate FNA, prostate biopsies are very, very common, but prostate FNA is very uncommon. I don't know if I've actually ever seen it, but I guess I could. And here are these kind of tall columnar cells that produce fluid to help sperm live, since they're down to bare bones. They need nutrients from the seminal fluid to live on their journey. This is the seminal vesicle, which is a paired organ sitting above the prostate. Seminal vesicle is cytologically very ugly and has a lot of nuclear pleomorphism. So pleomorphism means it's lots of different sizes and shapes. And the strange thing about it is that even though cytologically it's very ugly, but seminal vesicle cancer is vanishingly rare, and prostate is very benign looking and very bland, and prostate cancer is super rare. So it's just one of those weird things. You can tell that you're in the seminal vesicle because it has a lot of pigment. Sometimes it's hard to tell, but there's this lipofuscin pigment in the seminal vesicle that can be a giveaway that's what you're dealing with. But generally, that's more in terms of prostate tissue biopsies. All right. Connective or supporting tissues arise from the mesoderm, and it provides a framework which supports the epithelium and the other tissues. What does it do? It provides, again, support, transport, storage, protection, repair, all that good stuff. There are different types of connective tissue, and I'll have some pictures that illustrate this better. So you can have loose connective tissue, in which you're going to have more cells than fibers. Okay? It's going to be in the subcutaneous tissues and also the lamina propria. So lamina propria is that connective tissue that's right under epithelium, particularly in the gut, for instance, and we refer to that as the lamina propria. Dense connective tissue is going to have more fibers than cells, so it's going to be relatively paucicellular. And an example of this would be the dermis. Very densely collagenous tissue, like collagen or tendon, is an example of very, very dense connective tissue that has hardly any cells, but is mostly made of collagen. You can have elastic and large arteries and ligaments in the spinal column. Adipose tissue or fat is an abundant connective tissue type. Reticular really refers to the spleen and the bone marrow. The reticuloendothelial system refers to the spleen and the bone marrow. Mesenchyme, or the embryonic connective tissue, again, as cytologists, we're not going to encounter this or the mucus of the Wharton's jelly of the umbilical cord. I don't think as cytologists we would ever have that kind of specimen, but again, it's just important to be aware of them. Cartilage and bone we see frequently as cytologists, and it's important to recognize them. So what are you going to see as components of connective tissue? Fibroblasts are the most important. These are generally little spindle cells that have a rather low NC ratio, but are kind of, not only is the nucleus kind of spindle-shaped or pencil-shaped, so is the cytoplasm usually. Fat cells are adipocytes. Mast cells are commonly seen in connective tissue. They come from the bone marrow, and we'll see a picture of them in a second. Macrophages and monocytes, actually all of these other cells come from the bone marrow. So they didn't generate they just came there to live. So macrophages, monocytes, lymphocytes, plasma cells, eosinophils all came from bone marrow and took up space in the connective tissue. This is loose connective tissue. So it's going to have more cells than fibers. So there's a lot of daylight coming at you through this slide. Okay, it's not very pink, and there's mostly these little skinny fibroblasts. These are punctate little capillaries. filled with red blood cells. This picture is trying to show a little bit of the lamina propria of the GI tract and the loose connective tissue. So here's the epithelium. Again, the simple columnar, epithelium. And this, so filling up the core of this villus is the loose connective tissue, but as you can see, it's actually quite cellular, but it's full of inflammatory cells, which is normal in the GI tract to have inflammatory cells there. So it looks rather cellular, but it's all inflammatory cells. I think we'll have a better picture in a second. This is epidermis here with its keratinized layer. This is the dermis, and it's dense. There are many more of these dense collagenous pink fibers than there are cells here in the connective tissue. This is tendon, and it's very, very dense connective tissue. It has mostly pink, dense pink collagen and hardly any cells. An elastic artery wall. So this is the lumen of the blood vessel. The lumen is the opening to anything. This is where the red blood cells would be. And this dense, wavy connective tissue, this is the artery wall. We can do an elastic stain and highlight the elastin. So this undulating black line is the elastin, and here are the elastin fibers here too, which we can highlight with an elastin stain. All right, fat. So if you think of bubble wrap, which bubble wrap was invented by somebody who's like, you know what, fat does a great job insulating. How about bubble wrap? So if you think of bubble wrap, that's what fat is. That's what it looks like. So it's going to be these large empty cells, and generally the way we fix cells takes out all the fat, so they're going to appear empty because of the way that we because of the processing method that we use. Because usually the alcohol washes out the fat. So they're usually going to appear empty, big, voluminous bubbles. They do have a nucleus, but it's pushed all the way to the side, and it's usually very small. This is bone marrow. So bone marrow, depending on your age and the site where you take the bone marrow biopsy from, will have an admixture of fat. So it's normal to see fat in bone marrow. And actually it's very important when you look at final aspirations of bone or bone marrow is to note like how much fat is there. And so as you age, most of your bone marrow turns fatty. So in a younger person, they're going to have more cells and less fat. And as they get older, they're going to have more fat and less cells. I mean, it kind of makes sense. But you're going to have a jumble of different cell types in the bone marrow, which it will be addressed in later lectures. But just to be brief, there should be an admixture of large megakaryocytes. These are the cells that make platelets. You're going to have erythroid precursors, so the cells that are going to go on to become red blood cells, and the cells that are going to go on to become mature white blood cells. And you're going to see a jumble of these in the bone marrow. So what's abnormal to see in the bone marrow is one type of cell. One type of cell in the bone marrow is malignant until proven otherwise, because you should have a mixture of cells that make platelets, cells that make red blood cells, cells that make white blood cells. But should you see, for instance, any epithelial elements in the bone marrow? No. So again, that's why it's important to know what's normal with the site you're dealing with, because when you get an FNA and you say, wow, this looks like epithelium in the middle of this bone, you have to explain that. This is embryonic mesenchyme. So this is, generally, as a surgical pathologist, we generally see embryos in a woman who's had a very early miscarriage, and she comes to the hospital and passes some tissue, and we look at it under the microscope, and it's a bunch of blood. And often we can see sometimes very, very early embryonic development. And so it's going to have this loose connective tissue with kind of occasional pieces of cartilage, maybe a little bit of bone, usually some like kind of early eye formation or liver formation. But that's generally not going to be something that we're going to encounter as cytologists. It's generally as surgical pathologists. Similarly, the umbilical cord. I've never seen an FNA of the umbilical cord. I hope I don't, because I won't know what to say about it. But generally, the umbilical cord has three vessels, so 2 arteries and a vein. is normal, and it has this kind of loose connective tissue called Wharton's jelly that surrounds the vessels. Cartilage and bone. Cartilage has this very lavender appearance. Bone is much more pink or orange. When we stain it with this is an H&E, but also like with a PAP stain, for instance. Have you guys talked about stains at all, or? No? Okay. This is, again, like just an example of loose connective tissue with skinny fibroblasts, pencil-shaped cells, very loose, collagenous, has very few fibers. This is an admixture of fibroblasts and macrophages. So macrophages come from the bone marrow and they take up residence in connective tissue, and they serve sort of a garbage cleaning up function. They generally phagocytize or eat things and kind of are the cleanup crew for whatever kind of injury has gone on. So these cells here, they usually have kind of pigmented or stippled granular cytoplasm because of all of their phagocytic activity, and they have a small dark nucleus. This is in the background of these kind of whorled fibroblasts, which are generally, again, kind of long and skinny. This is fat again, just think bubble wrap. Mast cells, which again come from the bone marrow and take up residence in the connective tissue, they contain histamine, and they are densely granular, so they have granules of histamine that can be released when they are provoked, or if someone has an allergic reaction to something, for instance. We can highlight them with a special stain called toluidine blue, which just makes the mast cells stand out. And that's what this stain is. It's not usually used in general practice unless you ask for it. This is a histiocyte or macrophage. Again, it has very voluminous cytoplasm. It has a centrally located round nucleus, and it's full of particles of different sizes. And this is just debris that it's been eating here. These are common residents in, we often see these in FNAs of lymph nodes, because lymph nodes are turning over and cells are dying, even in the normal state. So histiocytes are fairly common. When we see them like this, it's usually in a lymph node. This is a tonsil with lymphocytes. So a tonsil is actually just sort of a modified lymph node in the back of the mouth. It's covered by a stratified squamous epithelium here, and it has a mixture of lymphocytes going through different stages of maturation. This is called a germinal center here, where the cells are bigger and larger. They're not so packed together, so it appears more open. This is called germinal center, and you'll have many more lectures about lymph nodes. Plasma cells and lymphocytes. These are two plasma cells right here in the center. And plasmacytoid is a term that we use very, very frequently in cytology. Again, it refers to, it doesn't mean that you're saying it's a plasma cell. It means that you're saying it's like a plasma cell. So plasmacytoid. So many, many tumors are described as being plasmacytoid, and they have nothing to do with plasma cells. What it refers to is this shape. So they're often kind of shaped like an Easter egg, sort of, or egg-shaped. And the nucleus is eccentric, so it's pushed off to one side. And it has a little clearing next to the nucleus. It's called a Hof, H-O-F, which is a German word for a hill. And it's where the Golgi apparatus, so plasma cells make antibodies. They're pumping out antibodies. So when you get a vaccination, your plasma cells get all revved up and they churn out antibodies to whatever you've been vaccinated against. And so because of that metabolic activity, they have this clearing here called the Hof. And they have an eccentric nucleus. The nucleus is pushed off to one side. And the chromatin pattern is often described as clock face. It's like dark and clumpy, sort of like it's called soccer ball, or like a snickerdoodle. Do you know what a snickerdoodle is, that cookie? Yeah. It has a cracked appearance. So it has that kind of cracked, clumpy appearance. And this is a plasma cell. But just in the future, you're going to hear many, many tumors described as plasmacytoid. And that just means they are sort of shaped like this. Does not mean that they are plasma cells. It means they have that general shape. Lymphocytes are a little bit easier to recognize. This is not a really great picture of a lymphocyte. We'll have a better picture in a second. These are eosinophils. So eosinophil, the name refers to, so phil refers to love or affinity or affection. So so eosinophil means that it takes up eosin, the stain, really well. It loves eosin. That's where the name comes from. So the name Eosin actually comes from the goddess Eos, who was the goddess of the dawn, which is rosy colored. So knowing all of that, you can assume that eosinophils are going to be very pink and rosy, and they are. They are full of very red, pink granules, stuffed full of red granules, and they have typically a bilobed nucleus, so 2 lobes to the nucleus here. All right, we're going to have more pictures. Hold on. A better picture of a lymphocyte, I think, later on. So muscle tissue, we often see muscle tissue as cytologists, not because muscle is aspirated that often, but because muscle is sort of accidentally biopsied on the way to a lesion. So it's important to recognize muscle under the microscope because you're going to see it very frequently as cytologists. So striated or skeletal muscle. So striated refers to stripes because it has cross striations that we can appreciate under the microscope, and that's what striated means. And that's voluntary muscle. So the muscle, like your bicep, for instance, is a voluntary muscle. It's going to be a skeletal muscle. Any muscle that you can move by thinking about it is a skeletal muscle. Smooth muscle is involuntary. It's not striated, so it does not have those cross striations under the microscope. And this is any kind of muscle that you cannot move by thinking about it. You can't make your gut move by thinking about it. Okay, anything like that. Cardiac muscle is kind of in between because it does have cross striations, but you are definitely not thinking about making your heart beat right now, right? So it's kind of in between because it is it's striated, but it's not under your willful control. So this is skeletal muscle. Here, it's big pink fibers, and if we are under the microscope and we're focused up and down, you can see those cross striations. Importantly, they have a nucleus that's pushed off to the side. So they have a peripherally located nucleus in skeletal muscle. This is something that you will see very, very frequently throughout your career. And it's important to recognize skeletal muscle. You often see it in thyroid FNAs because they'll accidentally clip some of the neck muscles on the way, and you'll see a little piece of skeletal muscle. Smooth muscle, however, does not have those cross striations, and the nuclei are in the middle. And it tends to have more nuclei that you can see. This would be the wall of the gut, for instance. Cardiac muscle does have a centrally located nucleus, and these kind of sharply define what we call intercalated striations here. And again, it's kind of halfway in between smooth muscle and skeletal muscle. You definitely don't want to see this on FNA. Something bad has happened if you see this, right? So nervous tissue is derived from ectoderm and mesoderm. It performs the function of communication, both outward and back to the brain. There are 2 main types of cells, neuroglia and neurons. So neurons are kind of the decision makers, and neuroglia are sort of the nerve cells that support the neurons. In terms of neuroglia, astrocytes are the housekeepers. They nourish the neuron. Oligodendrocytes create CNS myelin, and they wrap the neuronal processes in myelin. Ependyma is something that actually we encounter fairly frequently in CSF specimens. It's important to know what ependyma looks like because it can show up when you're not expecting it in certain specimens. And this is an epithelial lining of cavities in the brain and spinal cord. So it's important to know about it because you might be thinking about something like, oh, if I see epithelium in the CSF, it's definitely metastatic carcinoma. But that's not always the case because there is an epithelium that is supposed to be there, and that's ependyma. So you have to know what you're dealing with. Oh, and so when we refer to carcinoma, so carcinoma is any kind of cancer of epithelium. Okay. Microglia are macrophages that are mesodermal in origin that have migrated to the brain and do their kind of cleanup function in the brain. Schwann cells wrap peripheral nerves in myelin. Oligodendrocytes wrap CNS neurons in myelin. So a neuron consists of a cell body and at least two processes. So it has a central body, and then it has one arm going this way and one arm going that way, at least one. And it's wrapped in a myelin sheath that helps with conduction. I don't like this picture very much, so I'm going to skip it. All right. So if we look, this is a section of brain. This is a neuron here. It's much larger than every other cell around it. You can kind of picture it's sort of triangularly shaped. These more like long skinny ones are astrocytes. And the cells that have kind of a fried egg appearance or sitting in a little cavity, those are oligodendrocytes here. Another picture, so the larger cells are the neurons with the processes going this way and that way. And it's a little hard to tell, but this is probably an oligodendrocyte here, and this is probably an astrocyte. Again, oligos kind of have that fried egg appearance, and this is a neuron here. You can see these occasionally in CSF specimens, and someone that's had some kind of brain instrumentation, whether they've had surgery or they have a shunt or something, and they sample the CSF, you can kind of sometimes see little chunks of brain in a CSF specimen, and so you actually can see neurons sometimes in cytology, but it's not frequent. This is the ependema. So this the ependema secretes cerebrospinal fluid. So your brain and spinal cord are kind of sitting in this little bath all the time, and these are the cells that create it. So these are the epithelial cells that belong in CSF specimens if you see them, which again is fairly rare. Okay, just a few slides about mobile cells and blood cells, and you're going to have more lectures on lymph nodes and morphology, but this is just to introduce you to the concept. So red cells, or erythrocytes, so erythro means red, and leukocytes, leuko means white. So somebody that has leukemia, for instance, leukemia has its name because way back when, if somebody had leukemia and they took their blood and spun it in a centrifuge, they would have so many white blood cells that it would appear white, and that's how they got their name. They're not actually white under the microscope, but they are white to the naked eye if there's a bunch of them all together. So these you can divide them into a couple different categories. Granulocytes, so they're going to have granules. So polys, or polymorphic neutrophils, eosinophils, and basophils are all going to have granules. And then the agranulocytes, which are not going to have granules, as their name would tell you, are lymphocytes, monocytes, and platelets. So in a peripheral smear, you're going to have red blood cells, seen here. Platelets are these little guys. They don't have a nucleus. They've been extruded from those giant megakaryocytes in the bone marrow, and they are very small. This is a lymphocyte here. They can have like more or less cytoplasm, but in general they have a very high NC ratio. And this is a neutrophil, so it has several segments to the nucleus with a little skinny connection in between, and granules. Another peripheral smear, so these are red blood cells in the background. Remember, they don't have any nuclei in the normal state. These are platelets here. This is a neutrophil, and a monocyte here on its way to become a macrophage in the peripheral tissue. All right, again, another peripheral smear. This is a monocyte here. A poly, they're known as neutrophils or polys. People have different sort of nicknames for them. This is a basophil. So basophilia refers to the property of taking up a lot of a basophilic stain, and in this case it's a right Giemsa, but in H&E, if something is very, very purple, it's referred to as basophilic, and this cell is just called a basophil, kind of like the eosinophil, just named by its staining properties. This is a basophil. You hardly see any of these in the peripheral blood. They're very rare. They should be very rare in the normal state. This is an eosinophil. It's bilobed here. There's two lobes, the skinny little connection between a bunch of red granules, which are refractile. So refractile means if you focus up and down on it in the under the microscope, it kind of it's kind of hard to explain, actually. I don't know. Anybody have a good explanation for refractile?
It changes the plane of light.
It changes the plane of light.
So it's like a mirror. You know, shine it like this on light, how the prism comes on.
Yeah, it's hard to explain. It is hard to explain, but it's kind of like one of those things like you know it when you see it. And this, its neighbor is, what is the cell? A lymphocyte, exactly. Exactly. These are all lymphocytes. Probably. This is not a great picture. It's kind of hard to. Yeah. This actually probably is a chronic leukemia, but who knows? Okay. Oh, and this is an awesome picture because it has everybody's here. So it has a platelet. It has a. What's this one? Yeah, polybandish, sort of this guy. Yeah, this one. This one? A mono. This one. Yeah. This one. Exactly. It is a nice picture. I think it's the last picture. Okay. Any questions? That was a lot of material, and again, it's really not going to make sense until you learn more later, which is unfortunate, but the way it. But does anybody have any questions? Huh? Where's that?